This slide talks about trigger sensitivity. Again, this is a review. We've talked about that before. We're going to set the pressure sensitivity at -2 centimeters of water pressure, and that's pretty common for all hospitals. We did talk about flow and how flow is easier, it's more sensitive. The reason why we say it's best for those with auto PEEP is because it's harder to start a breath if you're still exhaling, basically. So when we have auto PEEP, that means there's air left in the lungs. So we're not only pulling through the circuit, the ET tube through the circuit, we're also pulling the air that's left in our lungs through the ET tube and the circuit. So as you can imagine, pulling from here plus all of this, it's extra work. So you may have to change to flow is what they're saying. I think ideally we would just get rid of the auto PEEP. That would make more sense to me, but that's what your book talks about. And the next slide talks about the IE ratio. Normal is IE ratio. Normal is 1 to 2. We've talked about that several times before. If you have somebody who has COPD, air trapping, it could be 1 to 3 or 1 to 4. We've talked about that. The second number is expiration. So the bigger the second number, the more time it takes them to exhale. Sometimes you'll see something called inverse IE ratio, as the next slide talks about. And that is something that we do with like ARDS patients, patients with really low compliance. So they will actually inhale longer than they exhale. So it's like inhale, exhale, inhale, exhale, inhale. So it's backwards. We do that again for ARDS patients, low lung compliance. We do that to increase their mean airway pressure. We increase their mean airway pressure to increase their oxygenation. Okay, so again, we have to watch out for their heart, their cardiac output, their blood pressure. Is it staying up with this inverse IE ratio? But again, their lungs are going to be so stiff, it's probably not going to squash the heart. And so that's what the next slide talks about. As we continue on, it looks like we're going to talk about gas flow. So normal peak flow that you're going to set on your vent is 40 to 80. We just generally start at 60 and go from there. And we watch the waveforms to make sure they have enough time to inhale and enough time to exhale. If we have too fast of a flow rate, it will increase raw. And if it's too slow, the patient's not going to be comfortable, it'll increase work of breathing, that type of thing. So we look at our flows, we look at our I time, we look at our waves, we look at our E time, our raw, auto PEEP, and that kind of thing. And that will help us set our flow. Again, normal 40 to 80, and we generally just start at 60 liters per minute.